Yavuz abi hoş geldiniz.
Good evening, Jan. Good afternoon.
Thank you. Good afternoon, Yavuz.
Good to see you again. How are you?
I'm still fine, as I told you.
No, from our talk 2 days ago, I find out that you have some milligrams of overweight, perhaps. Okay. I'll just try to arrange everything. Bye. So thank you for accepting to participate in our meeting. But you are can you switch off the screen? Sharing your screen, because I will introduce you in the beginning. Then you share screen, okay. Perhaps.
I stopped sharing my screen now. Yes.
Okay. Now it's better.
Yep.
We can chat with the civilized manner. I will show 2-3 slides for introduction.
Perfect.
Okay. I introduce you, and then you share your screen.
Yes, I will.
So how are the things? Everything fine with grandchildren?
We had a lovely weekend. All the children and grandchildren were here. And still we have one grandchild here because he and his parents are leaving tomorrow for 6 months for vacation.
Leaving to where?
To the south. They bought a camper and they are driving south. So first to Spain and Portugal, and then they hope to drive to the east. So I don't know where they end.
No, but I know you don't like heat, summer heat. You don't.
No. We told them already. It might be a little bit too warm for all three of you, but okay. I don't think that they will go to Norway or Sweden, but at least first they start in the south. But in the middle of the vacation, they have a wedding, not their wedding, but they have a wedding in Munich. So they might drive to Munich and then decide either going south again or going north.
Look, who joined us today? We have a special guest.
Zubi. Yes, I know. But he's contagious. He's still ill.
He's still ill, but I don't think the virus will jump through the screens.
Oh, there he is in the flowers. But for me, it's the first time.
Good to be all together here. So the session will be 1.5 hours something. Well, it depends on you, but usually sometimes we expand it, and because there's nothing afterwards, and we are online. That's the good thing with the Zoom meetings. Sometimes it takes very long, but you know, if it is too long, then people start sleeping.
No. Although I have a lot of slides, the point is that I don't put too much information on the slides, otherwise they get bored. So something at least is moving on the screen.
Fine. Sarah, we can see you. Your camera is off.
Because I'm on the road and I will switch my laptop in a second minute. And
Zubi joined us as well.
Really? It will be nice. And hi to Mr. Professor Wondergem.
Hello.
I will switch my laptop in a minute, okay?
Okay, perfect.
Sarah is one of the two directors of the course. Mm-hmm. This is a 15 weeks course. Mm-hmm. Includes an exam in the end.
It will be. And we will wait your questions.
Yes, you have to prepare questions.
Five questions for the residents.
5 questions. I will write it down, yes.
5 very difficult questions.
But is it an open question or multiple choice?
Multiple choices, please.
Okay.
How are you? Good to see you again. In good shape. You are mute.
So everybody is waiting.
Yeah, we will start on time. 7 minutes.
Yes, perfect.
We still have 10 minutes to begin.
And Zubi is coming to Turkey, Greece, and Turkey by boat. And we hope to have this year, finally, we'll have vacation together.
Aha.
Hopefully.
So he comes sailing to Izmir.
Yes, I hope so. You know, the Mytilene Island, the boat is anchored now. It's only 20 minutes. You are muted still. Good evening, Beste. Beste joined us. Beste Atasoy, she is the together with Sarah, she's the director of the program. Mm-hmm. Good evening, Beste.
Good evening.
You are muted, Beste.
The administrator is the one who managed who is muted or not.
All right. I think. Okay, can you hear me now?
Yes.
Yes, I can hear you. Yes.
Good evening. Good evening. Very welcome to our radiobiology course. We're very happy to listen to you in this course.
And Sarah joined us as well. These ladies are the directors of the radiology program.
It's nice to. It will be.
I'll have a picture together.
Hi, Zubi. How are you?
Fine. You are?
What a nice background.
Your daughter?
Sorry?
Fine.
Your daughter?
My daughter. She is in the college right now, in the university.
She will be a dentist. And
she will be a dentist. In the future, we hope so. And Professor Wondergem.
She has a daughter and a cat.
Yeah, we have 2 daughters actually. And Beste already have, please.
Beste, how many daughters do you have, Beste?
Beste, what's the final number of your children?
Cat's number you're asking. Okay, 1, 2, 3, 4, 5. 5 cats.
And believe or not,
be honest, please.
Of course,
be honest.
And ladies, believe or not, this young guy, Jan, he has 5 grandsons. 5 grandchildren.
No. Grandchildren, yeah.
4
granddaughters and 1 boy.
And he still looks very fresh and
Yes,
I play with
well.
them, with Duplo. Yeah, that's my level nowadays.
We were together. Beste, perhaps you don't meet Zubi before, previously.
Actually,
Zubi was
yes,
at
this
the
is
IAEA,
the
he was a section head, and we were working together. Zubi, myself, and Jan, we were the best buddies.
The good old days.
Nice to meet you.
Yes.
Now they are all retired, and
you're still working.
I'm still working, unfortunately. Zubi has grandchildren as well.
Mm-hmm.
You have grandchildren as well.
Yes, I will have 3 in a few months.
Yes. And you still look young as well. So 3 minutes to go. I will first introduce Jan, and then we continue. Our program, most people are watching us from YouTube, so not too many people are at the Zoom. So you may find it 13 people very low, but no, people are watching through the Zoom, and it's recorded also. I will send you the address of the record, Jan and Zubi as well. And people can ask questions through the chat, and I will direct it to you. Yeah. Okay.
And I gave you the PowerPoint presentation, and you can share that with all the participants as you like.
Oh, thank you. Thank you so much. We'll do it. Okay. I will share it as well. People can ask questions through the chat, and I will direct it to you. Yeah. Okay.
Mm-hmm. I think somebody's YouTube link is on one of person's screen at the moment.
Yeah.
Yeah. Can we close it? Yeah. Yavuz abi, sizin YouTube'unuz açık değil mi? Oradan geliyorsa. Tamam.
Şimdi sessiz herkes. Yani birisi şey yapabilirse YouTube'dan izleyen Zoom'u kapatsın lütfen. Zoom'dan izleyen de YouTube'u kapatsın. İkisinden
Ya da
birisi.
sesini evet kapat.
Evet. Çünkü YouTube arkadan geliyor. Ve sesler görüşüyor.
Let me remind.
Ecem kapatıyor sesleri, değil mi Ecem? Buralarda. O takip ediyor.
Evet hocam, ben takip ediyorum.
Well, I would like to remind to our guest lecturers, we expect 3 questions for the quiz, for each presentation. At the end of a presentation. I mean, you may send us via email in a couple of days, because in 2 weeks later we have a quiz, and we should prepare the questions.
Is the quiz a test, or is it separate from the test?
It's a test.
No. But you can also call it a quiz, and then they think, okay, they are less nervous.
This is because this will be online exam. So they will multiple choice, and they will click, and it's not a live test.
No.
So it's impossible to do only multiple choice. Okay, so can we start?
I think we can wait a couple of minutes.
Okay. You are the boss.
Yes, estağfurullah. Yani 4 ya da 5 geçe başlayabiliriz. Benim saatim 1 geçiyor.
Start in 2 minutes. Yeah. Başta dediğiniz zaman başlayalım. Beste Serra.
Hocam başlayabiliriz isterseniz. Yavaş yavaş geliyor çünkü. Buyurun.
İyi akşamlar. İyi akşamlar değerli izleyiciler, sevgili konuklar, öğrencilerimiz, arkadaşlarımız, hocalarımız. Bundan sonra bugün bir yurt dışından bir konuğumuz var, Jan Wondergem. Kendisi İngilizce konuştuğu program İngilizce olarak, ben de İngilizce olarak devam etmek istiyorum. Good evening, ladies and gentlemen. Today we have with us my dear friend Jan Wondergem. He's from Netherlands. Jan is a graduate of the Free University of Amsterdam, and he did his PhD on radiobiology and hyperthermia. He's an expert on these topics, and he was the associate professor at the University of Leiden. He's retired, but he still gives lectures, especially for us. And then he was also a former radiobiologist. He was employed as a radiobiologist, staff at the Applied Radiation Biology and Radiotherapy section of the IAEA, the International Atomic Energy Agency at Vienna. And I know Jan from his time in the IAEA. We worked together at the same section. We had a very nice group there, and we still continue collaboration and friendship since those years. So Jan is not, he's familiar to Turkish colleagues. He lectured in Turkey at least 3 times, so far I know, in the Arome courses in 2010, 2012, and 2015. He was teaching us. And I'm sure some of you already got live lectures from Jan. And today he will be with us to teach on radiation carcinogenesis in utero and hereditary effects, and low-dose radiation exposure and its effects on radiation workers. So welcome, Jan. It's good to see you again after this whole COVID thing. I know you are very busy with raising grandchildren. Jan has 5 grandchildren, believe it or not. And he's sailing in Amsterdam, and he's raising his children, and he accepted our invitation. And I'm very, very pleased to introduce Jan Wondergem for 2 very, very useful lectures on radiobiology. Jan, the floor is yours.
Okay. Thank you, Javus, for this very nice introduction. And I hope that I put in now, share my lecture. Yes, there it is, and there it comes. As you can see, it has the same title as what you suggested me, but I took the freedom a little bit to change a little bit the order of all the different components of this talk. And here I show you the outline of what I want to do this evening. In fact, I split 2 talks into 5 little ones. A little introduction on the effects of radiation, deterministic versus stochastic effects. Then a little part is on radiation carcinogenesis, followed by low dose radiations and its effect on the population and radiation workers. And also I will show you some risk estimates. And then in fact, the second part is on radiation effects in utero and hereditary effects of radiation. So I will start with the biological effects of radiation, and you can look at the individual, or you look at the descendants of the offspring of the individuals that were exposed to radiation. For instance, the radiation dose can be that high that it induces cell death or tissue damage. And we call that deterministic effects. We also look at radiation-induced cancer, but then we call it a stochastic effect. Several effects of radiation in utero can be stochastic, so cancer, for instance, or deterministic, that you can see neonatal death or organic defects. Another deterministic effect can be when the gonads are irradiated, is radiation-induced sterility, but it can also have effect on the offspring, and then it has a stochastic effect. But what is deterministic and what is stochastic? I will start with stochastic effects. They are random. So an effect is called stochastic as the chance and not the severity of the effect increases with the dose received. So when you received a high radiation dose, the cancer will not be more severe, but the chance of getting the cancer will be higher. Stochastic effects might occur as a result of radiation damage to a single cell component. And the most important cell components are DNA, so it will be a result of DNA damage. The severity of the effect is independent from the radiation dose, and the major stochastic effect is cancer and genetic effects in the offspring. The probability of stochastic effects increases linear with increasing radiation dose. And here on your right-hand side, you can see the dose going from 0 to high, and here the incidence from, say, 0 to 100%. And it's a linear relation between the dose and the incidence, and there is no threshold. So we call this the linear non-threshold model. So there is a linear relation between the dose and the incidence. So at the 0 dose, there is a 0 incidence. And there are exclusively late effects. So stochastic effects, you don't see that a few hours or a few days after radiation, but you have to wait months to years and sometimes even decades before you see those effects after a radiation exposure. Then I talk about deterministic effects, and I studied a lot of the deterministic effects because one of the points of the study that we did in my laboratory was late effects of radiation damage in the heart and in blood vessels. But those are deterministic effects, and there you can see that when the dose is significantly high, you can damage living tissues. So at a low dose, you don't see any effect, but at higher doses, you really see that effect. And those effects are due to extra cell loss. You have your normal cell turnover in tissues and in organs, and that's the balance between cell death and production of new cells. But the normal cell turnover in those tissues after irradiation is disturbed. So, for instance, dividing cells are very sensitive to radiation. No dividing cells, that means no normal or no new cells delivered. And normally cells will die in organs or tissues or maturate, and not capable of giving an offspring. So that is disturbed, and you will see at a certain point a shortage of cells, and then you see tissue or cell damage. Now, when you look at the deterministic effects, the severity of a deterministic effect increases with radiation dose. So there is a real relation between the radiation dose and the severity of those effects. And those effects may already occur soon after exposure, a few hours, for instance, when you irradiate bone marrow, or days when you irradiate skin, but also after longer time intervals, fibrosis, cardiac damage, brain damage. You can see late effects after high doses of radiation. What is important when you look at here the dose response curve, and here, for instance, organ failure probability, and here the dose, that it's not a linear relationship, but you see an S-shaped curve, and that's a sigmoid shaped curve. First, you see when you increase the dose, a slow increase of, in this case, organ failure, then a more rapid increase, and then at the end, with the very high doses, almost all organs failed in this case, that certain particular organ failed in function. There is usually a threshold, so below that threshold, you don't see any damage of radiation, although there is damage. But at a certain point, the models or the methods to describe or to measure the damage are not sensitive enough to see under the threshold. Under the threshold, of course, there is cell death, but you can hardly notice it. So only after a certain number of cells that have damaged or died, then you can see an effect on the tissues. So when we now go to the first subject of the talk, in fact, radiation carcinogenesis. What is radiation carcinogenesis? Radiation carcinogenesis is a biological phenomenon whereby living normal cells are damaged by ionizing radiation. I told you already about that. And these events may start a progressive process causing the surviving cells to change their phenotype in such a way that the normal cells, controls of cell death and apoptosis are lost. So they don't die after damage anymore, or they don't go in apoptosis anymore. So they grow uncontrolled. And this is the last stage, in fact, and then we call it also cancer, when we have an uncontrolled cancerous growth is initiated. Then I talk about radiation carcinogenesis. It all starts, in fact, with the LLS study, the lifespan study, that was initiated after the Second World War, after the A-bomb in Hiroshima and Nagasaki. And what I also want to talk about is that carcinogenesis is not a one-step process, but it is a multi-step or stage process. And it involves also the cell cycle, interphase, and cell divisions. And proto-oncogenes become oncogenes, and also suppressor genes play a very important role in this process. And we can also measure or see expression of protogenes or proto-oncogenes and tumor suppressor genes in human cancers. So I will just shortly pass by all these little subjects. This is for instance, the first picture from the lifespan study. And in this study, you can see here the years after the exposure of the people in Nagasaki and Hiroshima. And in fact, in the lifespan study, there were more than 80,000 people, half of them exposed to radiation, and the other half was a cohort living in the same area, but that cohort was not irradiated. What you can see here is that they had to wait a couple of years, and it was around 1950 that they saw the first cases of leukemia arising in survivors of the A-bomb. And the latency period for leukemia is about 3 to 5 years. And then there is a certain risk period up to 40 years. So in this period, you can get leukemia induced by radiation. When you look at other type of cancers, say solid tumors or so, you have to wait much longer. So the time in or the latency period or latent period is much longer, and the risk period is in fact lifetime. This is in fact the first one of the first pictures that were shown that we talk about latent periods and also the risk period. Here, for instance, the latent period for different types of cancer, leukemia, 8 to 10 years, thyroid cancer, less than 20 years. There are already thyroid cancers a few years after being exposed to radiation, bladder cancer, breast cancer, 20 years, head and neck tumors, say about 20 years. Bone cancers can be very early or relatively early, but also very, very late. And skin cancers, you see latency periods of 25 years up to 42 years. Next to the latency period, we talk about the risk period, and the definition of that is the period in which the risk to get cancer is increased, and that's the period, in fact, between the minimal latency time and the maximal latency time. So this is what we first learned from the lifespan study. But nowadays, almost every laboratory is studying DNA damage after radiation and the relation between DNA damage and carcinogenesis, so development of cancer after being exposed. And one of the most important things that you have to remind yourself is that a single alteration, so say the DNA damage, and it is very often double strand breaks or mutations or chromosome damage, that single alteration itself does not lead to the formation of a solid tumor. No. The development of cancer in tissues is assumed to be a multi-stage process. So there are a lot of things that have to be happening, need to happen between the radiation-inflicted alteration in DNA and later on in the development of cancer. And we talk in that case about promotion, conversion, or first, in fact, the initiation, promotion, conversion, and then the progression. And I can show it in the 4 stages in this slide. The multi-step process in 4 stages. Neoplastic initiation is, in fact, exposure to radiation. So 1 or more mutations develop. Because of that, you have DNA damage, you have chromosome aberrations, so damage to the chromosomes, and that's the initiation. And then there is a promotion stage, and also intracellular events affect the development of the cell or the offspring of that cell into cancer cells. Also, growth factors play a role in that. Do the cells frequently die or not? Or hormones play a role of that. And of course, also environmental agents. For instance, when you think about lung cancers induced by radiation, does the person smoke or not smoke? And then later on, the conversion. So that's 1 step further. There are additional mutations in important chromosomes and mutations in chromosomes that are responsible for the cell cycle, for instance. Or there are deletions. And that means that, in fact, not all the genetic material are divided well between the mother cell and the daughter cell. So there is an increasing loss of genomic stability. So they become unstable, in fact. And more, and that's in the progression phase, and that's in the pro-cancer phase, more mutations in the unstable chromosome. They lead to mutations in cancer-associated genes and also in DNA stability genes. So all those changes finally lead to the development of cancer. And this is, in fact, a simplification of all the processes, but to make it simple, we talk about here about 4 stages. And in the next picture, you can see it again, in fact, the initiation, promotion, conversion, and the progression, but also the time frame initiation of the damage is in 1 or 2 days. And it's in fact irreversible. But then we have the promotion and the conversion phase, and that's a very long phase that can last 5, 10, 20 years or even longer. Some may be reversible because you have an immune system in the body. So that immune system might recognize the damaged cells and clears it up. But it can also be the case that it doesn't recognize it and that the damaged cells becomes a pre-neoplastic cell. And then when it in a pre-neoplastic stage, it will develop into cancer cells and grow faster and faster and does not obey the cell cycle anymore. Just to remind you, what is the cell cycle? I talked about that. The cell cycle is in fact a cell spends most of its time in the interphase. And in the interphase, the chromosomes duplicate and cell parts are made. And that's in fact 90% of the time of the cell cycle. And the cell also functions normally. At the end, this can be the mitotic phase and the cell starts to divide. So there is mitosis and cell division. After mitosis, the cell has to rest. There's a gap 1 phase because it's a quite stressing event to divide for the cells. But when the cell has recovered, in fact, then it can go to the synthesis, the S phase. And in the S phase, you have the DNA replication. It's also a stressful period. And then it goes into the G2 phase, the gap 2 phase, and then it can go into division. Proto-oncogenes, suppressor genes, and DNA repair genes play a very important role in controlling the cell cycle. And what are they doing in fact? DNA repair genes fix the errors in the DNA. So they fix single strand breaks, double strand breaks, etc., etc. Proto-oncogenes stimulate the cell to grow. So they stimulate the cell to go from the G1 phase. In fact, after the mitosis, it stimulates the cell to divide again. So to go into the G1 phase. And it also pushes the cell from the G1 phase to the S phase. And from the S phase to the G2 phase, and then again to the mitosis phase. On the other hand, the suppressor genes act to stop cell growth. So when you compare it a little bit, proto-oncogenes are in fact the gas pedal, the accelerator of the cell cycle, and the suppressor genes are the brakes. So when something goes wrong with the brake or with the accelerator, cells behave differently. And here you can see what these proto-oncogenes or the tumor suppressor genes do. Proto-oncogenes are in fact normal genes involved in growth regulation of the cell cycle. But mutations, so cells become, or the genes go from proto to oncogenes. Mutations, for instance, by the translation of a promoter may result in an increased rate of proliferation. That can be because there is an overexpression of oncogenes. So proto-oncogene mutations to oncogenes are classified as a gain of function mutation because the cell goes or wants to divide and wants to divide more. On the other hand, we have the tumor suppressor genes. They're also involved in growth regulation and they prevent excessive cell proliferation. And here it's a critical mutation or a deletion in these genes, and we call it loss of function mutation. And for the tumor suppressor genes, you need 2 important mutations to disactivate, in fact, the tumor suppressor gene. So it's generally assumed that the inactivation mutation of tumor suppressor genes is the most probable mechanism for the induction of cancer by radiation because there is no brake left. And on the other hand, there's always someone pushing on the gas pedal or the accelerator. These are some cancer-associated genes that are involved and that you can really measure. The RB gene or the P53 gene. A long time ago, that was seen as the most important gene in the world, but now we know that there are more important genes that are involved in the cell cycle. We also have oncogenes, the NRAS, c-MYC gene, gain of function. As you can see, they are involved and also found in different tumors. And also mutations in DNA repair genes. They already found, when I made this slide, more than 80, but I guess there might be already more than 200. For instance, breast cancer gene 1 and 2, and also the gene that is, important in colon cancer. Here's some of the oncogenes that you can find in the tumor when you have biopsy of the tumor. NRAS, KRAS in neuroblastoma, KRAS in breast and lung and ovary, c-MYC in the lymphomas, breast, stomach and lung, BLC2 in lymphomas, ERB2 in breast cancer, lung adenoma, and also the knowledge of expression and the amount of expression that you see in the oncogene of the tumor suppressor genes might give you a clue a little bit about how to treat the tumor and what is the future or what is the success or what might be the success of your treatment. And these are different tumor suppressor genes for nervous tissue, brain, P53 in several cancers, BRCA in breast and ovary cancer, VHL in renal cancer. So this is also only a few oncogenes and tumor suppressor genes, but you can find much more in the different types of cancers. So from carcinogenesis, I jump over to radiation workers and cancer. And for that, I will discuss with you the LNT model, linear non-threshold model, and extrapolating, in fact, from high radiation and high dose risk dose data to low dose risk models. Also, the terminology of DDREF, dose and dose rate effectiveness factor, detriment and lethality. Also, there are different risk prediction models because, we want to predict, in fact, what is your risk. And there are two important models about the absolute model and the relative risk model. It also is lifetime cancer mortality dependent on the age of exposure. Another thing is total body exposure or is only a part of the body exposed to radiation. So we have also tissue weight factors. And also very short in one slide, cancer risk among radiologists and radiological workers. Here you see, again, the linear non-threshold model. Here with the dose and here the excess of cancer incidence. And this is a linear relation between the dose and the cancer incidence. Here you see some dots, and here are some really observed data. And these are data that came from the LLS study, so from the Hiroshima and Nagasaki study. But you see they are, in fact, in a relatively high dose range. But what we want to know for protection is, in fact, what's happening below and under 100 millisieverts. We don't have, in fact, any data. So we have to guess what's happening. A lot of studies were carried out with different types of cell lines. And that's, in fact, on the right-hand side. And from that, you can see in certain cell lines that there is a hypersensitivity. So that there is not a linear non-threshold relation, but even at a very low doses, there might be more sensitive. But a few studies show that. Other studies show that there might be a little threshold because below a certain dose, we don't see any excess risk. And there are even data on hormesis that when you are firstly exposed to a very low dose of radiation, that when you get a second dose, that you might be a little bit resistant to it. And you can find that in studies where people with drugs or with chemicals, but this was very surprising to see in only a few studies that you can also see that in radiation exposed cells. But most studies, and also according to the hypothesis, we have the linear non-threshold model. And in general, when we do any estimates on that with the very low dose, we might give a little bit higher estimate, but in reality, it might be lower than what we have estimated. As I told you, that most of the data that we have are from high doses and high dose rates. And to transform those data to the low dose and the chronic doses, we have to adapt, in fact, because low doses and the low dose rate are less carcinogenic. And when you have a figure here higher than 1, it means that low dose and low dose rate are less carcinogenic than the high dose rate. So in fact, for our calculations and comparisons, we use a factor of 2, and ECRP found that factor in 1990, and again in 2007 in that publication. Again, they said, okay, there are different reports, but we are relatively on the safe side when we use 2 as the conversion factor, going from high dose results to low dose results. And what is then the risk for cancer, that is fatal or lethal cancer? What is then the risk for low dose, dose rate? For the individual is 5% per sievert, excess cancer. Radiation workers, and they are always older than 18 years, because below 18 years, you're not allowed to be a radiation worker. It's a little bit lower, it's 4% per sievert. And later on, I will explain you why there is a difference between radiation workers. Are they more resistant to radiation? No, they are not, but they are a little bit older than the whole population. And when you look at the high dose and the high dose risk estimates for the individual, 5% times conversion factor of 2 is 10% per sievert. And for the radiation workers, it's 8% per sievert. We use, in that case, the dose and dose rate modifying factor of 2. Next to fetal cancer, in publications, you can also read about detriment. And the detriment takes into account the risk of cancer with fatal outcome, but also the risk of cancer with non-fatal outcome, and also the risk of severe genetic disorders, or the loss of life years, so quality of life. And when you put that all together for the whole population, where is my, yes, for the whole population, you come up with a figure of 7.3% per sievert. So that's a little bit higher than the 5% for fatal outcome of cancer, of radiation-related cancer, and for the workers, 5.6%. Another important thing is when you want to make any predictions about the chance of getting cancer induced by radiation, are you using the absolute risk model or are you using the relative risk model? Here, for instance, you have your exposure, you have a certain latent period, and here on the right-hand side, you can see the spontaneous incidence of a particular cancer. Due to irradiation, in this absolute risk model, you see there is an excess incidence, and that remains the same for all the time, independent on the age where you were exposed to radiation. In the relative risk model, it's different, because in this model, it matters if you are irradiated at an early age or later on. As you can see here, the original curve, the spontaneous incidence, and this is the calculated excess incidence curve when you exposed radiation here and here. So with the relative risk model, you come up with higher doses. So age at the time of exposure strongly influences the calculated risk. And in the relative risk model, you always see higher figures, than in the absolute risk model. In the next slide, you can see that there is a relation between age at the time of exposure and the cancer risk. And here, when you're exposed to radiation at a late age, then the chance of getting cancer because of radiation is very low, also because of your latency time. Here you can see the 5%, because that's the average for the whole population, but females are a little bit more sensitive to radiation than the males are. And here you can see when you are irradiated at a young age, that you see that the risk of getting cancer is much higher than when you're an adult or when you're even an old person. So very young children are 10 times more sensitive than older adults. And in this case, also females are a little bit more radiosensitive than males, but that's a difference of 0.1, 0.2%. So you also have to take that into account. And that's why in radio protection, and also when you have to irradiate young children, or when you have when you need diagnostic X-rays and relatively high doses, that you're very conservative in doing those tests with young children because of the high risk for radiation-induced cancers. So we end up here for the child, for the low dose and the low dose rate, between 10 and 50% perceived of risk of getting cancer. Now we jump to the tissues. Are all tissues equally radiosensitive? Now, for that, we have invented the effective dose. And what is the effective dose? The effective dose takes into account that some types of radiation are more damaging than others. So there are weighting factors for the type of radiation you use. And also that some parts of the body are more sensitive to radiation than others. And the effective dose is defined as the sum of specified tissues of the product of the equivalent dose in a tissue and the weighting factor for that tissue. So I will show you different tissues and different weighting factors. The ICRP is already studying this matter since the late 60s, and they came up with the report in 1977 with different weighting factors. For the whole body, the weighting factor is of course 1. But they thought the gonads are very important for developing cancer. Bone marrow 0.12, lung 0.12, breast 0.15, thyroid only 0.03, bone 0.03, and the reminders of the organs were 0.30. But in very different epidemiological studies, they found, no, the gonads are not that sensitive to radiation when you relate it to radiation-induced cancers. So they lowered the tissue weighting factors from 0.25 down to 0.20. For bone marrow, it remains the same, but they saw a lot of colon cancers. So they gave it 0.12. The lung remained 0.12. The stomach became 0.12. So stomach and colon. The bladder, the breast, they thought, okay, irradiating the breast or breast gland. No, we don't see much breast cancers. But in later studies, for instance, the studies in survivors of Hodgkin lymphomas, and especially the young ladies that received a dose on the gland, you can see a lot of breast cancer developing in those cohorts. So they gave, again, the tissue weighting factor became higher again. So altogether, it's 1, and I will give you an example of how you use these weight factors in a simple equation. This is, for instance, an example of an X-ray examination of the neck with a certain dose. And the dose on the thyroid was 1 milligray. So that's very, very low. So what is the effective dose then? It's the tissue weighting factor times the radiation weighting factor times, where is it? Times the dose. So when I go back 1, you can see for the thyroid here, 0.04. So 0.04 times the weighting factor for normal radiation is 1, times the dose, 1 milligray, and you end up with an effective dose of 0.04 millisievert. If only the thyroid gland is irradiated, what is then the mortality chance? So what is the extra risk that you have? So again, you calculate here the tissue weighting factor you have, the radiation weighting factor, the dose, and your relative risk factor of 5%. And then you end up with 0.20 times 10 to the minus 5th. That is after 1 milligray. And that means that you have an excess of 2 extra people dying of thyroid cancer out of 1 million exposed persons. So that risk is very, very low. When you look at the radiation workers, in the past, when you look at the early workers, there is an increased mortality due to leukemia among the workers. And that was a very big study on the 270,000 employees and radiologists. And especially in the very old-fashioned radiologists, you can see also a lot of skin cancers. And also, there was an increase in breast cancer in female workers. But recently, when you also look at because you're monitored, there are no changes in cancer incidence in the current radiological worker cohorts compared to the non-radiological workers. And this is just one study, but there are several studies showing that. So because of all the protective measures, you work in a safe environment and there is no increased risk of getting cancer because of the work that you're performing. Now, this is in fact the first part of my talk. Do you want me to continue with radiation effects in utero, or ask me some questions, or all the questions at the end of the show?
I think at this point we can have some questions.
Mm-hmm.
Well, at least I have some questions. Yeah. The first thing you showed about the lifespan study, and there are some oncogenes.
Yes.
And although today there are a lot of treatment methods and drugs are developed against
yes.
other parts of the cancer process.
Yes.
We do not see too many attempts to get rid of the oncogenes, targeting oncogenes. Why do you think this? Why there is not too many studies about the
there are
suppressing the oncogenes?
Many of the studies are in the laboratory are quite successful, but they have a lot of side effects when you treat the patients with those newly developed drugs. That's a little bit a problem.
It seems to be an easy target. There's an oncogene that develops cancer, so if you kill the oncogene, then okay.
Yeah.
What side effects?
But the point is that mutations in the tumor suppressor genes are more important because then you lose the break.
Okay. So another question is that you said that the deterministic effect is a sigmoid curve.
Yes.
Is this sigmoid curve, is it same for all ages? A baby has the same sigmoid curve with a 70-year-old man, or
yes,
shape, or at least it's shallow or steep, or
no. In fact, all those response relationships are S-shaped when you look at deterministic effects, but the shape of the curve itself may differ. It can go to the left or go to the right. When you have a very when you have a very sensitive organ, it might shift to the left, and when you have an insensitive organ, it might shift to the right, and it may also be shallow for certain organs.
And then how will we know? You said it's some threshold.
You can find that from many lab studies with animals, and also the point is that when you want to do those studies in the clinic, when you define a certain area, a surface, not all. Yeah, how can I say that? Not all the surfaces are exactly the same, and also the sensitivity difference between patient and patients is quite large. And in animals, we use all inbred mice or rats, so they react all in the same way. So the S-curve, the sigmoid curve, is in fact a compilation of the different sensitivities in the different individuals.
So that there can be differences between the individuals.
Yes, because say that for a certain organ, a loss of 1,000 cells means an effect, then for one individual, you have to give a higher dose to get the 1,000 cells lost than for another individual that is resistant or sensitive.
Okay. One more question from me, and we have questions from the audience. My question is, you show that in the very low doses, there are some models where there's some, some cells are radiosensitive, even more radiosensitive than higher doses.
Yes.
Some are not so sensitive and very few sensitivity in low. How will we know this?
Those studies were all carried out with
very
cell
low doses, especially at the time of IMRT and VMAT, where we are irradiating large areas with
cells all
very low doses.
Yeah, I know that in Leiden, the group of Mulleners did a lot of work on that, and they irradiated cells or cells in tissue for a very, very long time with a very, very low dose.
Yeah, but then
and also different types of radiation they used.
You know, until today, I was a bit comfortable because we are doing VMAT in almost all patients, perhaps, and we are irradiating large areas with very, very small doses. And we are thinking that, okay, at these low doses, all cells are less effect.
Yes.
In your graph, it seems that some cells are more radiosensitive.
No. Some cell lines. Some cell lines.
Okay, cell lines.
And the point is that cell lines are in fact a very artificial model. In humans, we have never seen that. I think it was Philippe Lambert who tried to mimic such a study in animals in the Gray lab when he was there. And I think I go back 25 years or 30 years ago. And he only saw it in one cell line, the hypersensitivity.
I hope no more than that.
No. So that's why I'm safe to say, when we look at the linear non-threshold model and when we calculate everything according to that, don't worry too much.
Okay, then
because we don't know yet. We don't really know.
Okay, thank you. Then we have two questions from the audience. Beste Atasoy. Beste is asking, can risk models for low doses change due to tissue types and subtypes of organs?
Mm-hmm.
So it's the organ specific or tissue or subtype specific risk models for low doses? That's perhaps the same question of radiosensitivity.
Do you want to repeat that question? Because
Yeah, okay.
I don't.
Can risk models for low doses
Yes.
change due to tissue types or organs?
No, no, it's just no. I don't think that that it will influence. It's the tissue waving factor that might influence when they and they used it in the models to predict mortality rates after exposure. And that's what, when I go back here, you can see that over the time that there are more data coming, and then they give a bigger factor or a lower factor to a certain organ.
Okay, it's not okay. It's something. The studies are on organs, let's say.
These are, in fact, epidemiological studies that show that when people were irradiated with a certain dose or a certain area, so what is the risk of cancer? So they looked at hundreds of thousands people in different cohorts over a long period of time. And you have more and more cohorts because you have surviving radiation therapy patients, and you can also do these studies. And you can calculate exactly what was the dose on the different tissues that they received. And then you look at the incidence of cancers in those organs.
Thank you. And the last question in this section, Cengiz Kurtman, Professor Cengiz Kurtman is asking, what is the risk of second cancer after radiotherapy patients, and how many and why?
It's depending on the dose, yeah. But you give high dose and high dose rate. So that means that you have a risk of 10% per sievert or per gray.
And also it depends on the time for low.
And it depends on the time. So when you're a child, then you have an even much higher dose risk.
So it does affect the radiation type effects as well. For example, protons are more carcinogenic.
No, that's why they want to use protons, because then the amount of normal tissue that you irradiate is lower.
No, radiobiological. Let's say the same amount of tissue is irradiated with protons and photons.
Yes, yeah, but the average dose in the normal tissues is lower.
Yeah, okay. Okay, if I don't see any other questions, you can ask your questions at the end of the session as well. Then we can continue with the second part of radiation effects in utero.
Yes,
when we irradiate a pregnant person. By mistake, of course.
Yeah. I had, when we talk about, hey, where is this here? In fact, there is a lack of knowledge on this subject. People think immediately, okay, when I'm pregnant and then the fetus or the embryo is exposed to radiation, we have to terminate the pregnancy. But I hope that after this talk, people are less afraid of certain doses of radiation, and also what is the recommendation of the ICRP. Because in fact, thousands of people or pregnant women are exposed to ionizing radiation each year. And that can be planned, but in most cases it's accidental, but also occupational, because there's high background levels of radiation in that area. And when you look at the general population, and of course, you can be an A-bomb victim, and there are a lot of also studies carried out with survivors after the A-bomb in Japan. is there an increased number of miscarriages, etc., etc. The general population can also be part of a radiation accident or the background radiation. In patients, it's obvious that radiation diagnostics or nuclear medicine or intervention radiology and even radiotherapy might add up to doses to the fetus or the embryo. And also the medical radiation workers due to scattered radiation or also a radiation accident. So that's all possible that pregnant people become exposed to radiation. And in my talk, it's easy one because I talk about the pre-implantation period, organogenesis, and the fetal period. And just to define, conception is T0, pre-implantation time is 0 to 9 days, and organogenesis, development of the different organs between 2 weeks and 6 weeks, and the fetal period when the fetus grows is 6 weeks to term. So it's about a period of 38 weeks. And it's important to know that there are certain risks to radiation throughout the pregnancy, and they are related to the stage of the pregnancy and also to the absorbed dose. So are you early in the pregnancy or late in the pregnancy? Is the absorbed dose low or is it high? And the radiation risks are most significant during the organogenesis and in the early fetal period. And they are somewhat less in the second trimester and least in the third trimester. So that means that in the early period, the fetus or the cells are most sensitive to radiation, and in the later period, effects of radiation are less visible. What are the consequences of radiation? Here again, the deterministic effects, so effect with a threshold, severe mental retardation. Below a certain dose, you don't see any retardation, or you cannot measure any retardation. Or below a certain dose, you cannot see any growth retardation. Congenital malformations, abnormalities, you cannot see them under a certain dose. And also embryonic, fetal or neonatal death, you don't see it under a certain dose, and above a certain dose, you do see it. But there are also stochastic effects. There's no threshold. Induction of childhood cancer. From the previous picture, you could already see that young children are very sensitive to radiation. So what will happen with the unborn child when it got irradiated? And also we have genetic effects because of radiation. So the genetics changes in the offspring, you can find that. This is the pre-implantation phase. So 0 to 9 days after conception, we have only a few cells and they are not specialized. So they divide, they are pluripotent. You have 1 cell, 2 cells, 4 cells, 8 cells, 16 cells, modular, gastrula, stadium. And cell death leads to implantation failure or death of the embryo. And the incidence of prenatal death is very high, also in non-irradiated or non-exposed women. But there can also, it's also possible that the surviving cells, so when you're in the early cell phase, so in 3 or 4 cells, and cells are pluripotent and 2 cells are damaged and they are dying, you have 2 cells left. It's possible that 2 cells replace, after a few divisions, the lost cells, and you have a natural development of the embryo. So in fact, it's an all or nothing effect. Either the embryo dies or you have a healthy embryo. So in daily practice, you hardly know, in fact, because you didn't know that you were pregnant, and when you were irradiated, that when you don't get pregnant, that because of the high incidence of prenatal death, whether you are irradiated or non-irradiated, okay, it happens, but you don't know. So you didn't know that the embryo was damaged or that you didn't get a child because of that. It's different when you go to the organogenesis in the fetal stage, because then you have a lot of cells and you have an embryo. And the embryo consists of many dividing cells. So you will have a lot of organs that are being formed. And in this stage, you can see a high incidence of radiation-induced malformations. So developing internal organs, the eyes are developed, skeleton is developed, and there is a high incidence of neonatal death. So the embryo is damaged in such a way that it results in death also already before birth. A little bit later, between 6 and 25 weeks, you also have the development of the central nervous system. And there is a high incidence of microcephaly. So the major brain is smaller than in the non-exposed embryos. And there is also mental retardation. And you can find that also in one of the studies on the A-bomb survivors. And that study was done by Miller in 1976, and he looked at the children that were born between a few days and almost 9 months after the bomb on Hiroshima and Nagasaki. And what you can see here, the dose from low to higher, and here the gestational age, so the period of pregnancy. So this is late in the pregnancy and this is very early in the pregnancy. And this is the number of cases with microcephaly, the percentage of children that were studied. And you can see here in the early period, in fact, after the organogenesis, a little bit later when you have the development of the brain, that you have high incidence and also related higher with a higher dose. And also in this period, because of the radiation. So this is the time that you see that CNS, the central nervous system, is being developed. And when you're exposed to radiation in the later phases, you hardly see any difference or any incidence of children with microcephaly. And this is in fact putting together in this slide. During 8 to 25 weeks post-conception, the central nervous system is sensitive to radiation. Fetal doses in excess of 100 milligray, so that's 0.1 gray, can result in some reduction of IQ. And fetal doses in the range of 1 sievert or 1 gray can result in severe mental retardation, especially in the earlier period between 8 and 15 weeks. And then you have 2.5 to 3 EQ points per 100 milligray. So when you are exposed to 1 gray, it would end up with 25 up to 30 IQ points. And then to a lesser extent in 16 to 25 weeks. So then you can half or take a third of these figures, in fact. And we also have a lot of information because we don't have any further information on children that got exposed to irradiation, is from a big mouse experiment. And that experiment was done by Russell, man and wife. And they looked at the incidence of abnormalities or prenatal and neonatal death in mice given a dose of 2 gray at various times after fertilization of conception. And you can see that in this figure, and this is the time frame here. So the normal period for the mouse is about 14 days or 16 days, and then you get birth to a large amount of little mice. And you can see here when mice, the pregnant mice is exposed in the very early period, you see a high incidence of prenatal death, hardly any abnormalities, and no neonatal death. In the next phase, in fact, the organogenesis phase, you can see a further decrease of the incidence of prenatal death. You see an increase of neonatal death because the embryo, when it's born, there are too many defects and it dies. And you see also a lot of abnormalities in the, where is it? In the animals that were found after spontaneous abortion. And in the latest phase, between 13 days and delivery, you don't see any prenatal death, no abnormalities, and no neonatal death. And here you see a little bit the time frame, days post-conception for the humans, and this is for the humans in fact. So the period of organogenesis is very important for development of the organs, and you see a lot of abnormalities and neonatal death and no prenatal death. Here are some deterministic thresholds for instance, prenatal death in mice, because these are all from mice data. And okay, we transport those mice data to the human situation. The threshold for pre-implantation prenatal death is 100 milligray or 100 millisievert. Malformations, also 100 millisieverts. Malformations of the skeleton below 250 milligray, you don't see malformations of the skeleton. Growth retardation, and that's low body weight, you don't see it below 500 milligray, so half a gray. Reduced head circumference between 100 and 300 milligray threshold dose. And for the brain, mental retardation, you can see that 40% per gray in this period, in the between 8 and 15 weeks. But this is for the humans. Mental retardation, 16 to 25 weeks is only 10%. And then later on 25 and 38 weeks, you hardly see any difference when the brain of the unborn child was exposed to radiation. These are some data when in the unexposed group, natural risk in a pregnant population, but not exposed to radiation. You can see also already spontaneous abortion in the first weeks of the pregnancy is between 30 and 50%. Major malformations, 1 out of 17. Some mental retardation in 3 out of 100, but severe mental retardation only in 0.5%, and childhood cancer in only 0.1% in the non-exposed population. There is also a big study, a very big study on childhood cancers after in utero diagnostic X-ray examinations. And in fact, in the mid-50s till the early 80s, pregnant women were X-rayed many times to check if the child in the womb was growing enough, good enough. And the main dose that those fetuses received was between 10 and 20 milligray. And they had about 50,000 children and also matched controls in the group. And what they found was that there was an increased incidence of childhood cancer over the normal incidence of 40%. So there was a high increase of cancer with these very low doses. And they could calculate from these data that the risk of cancer, and it was leukemia at the ages of between 0 and 15. So they developed leukemia in those early years for individual exposed in utero to 10 milligray is about 1 excess cancer death per 1,700. And that is translated into 6% per gray. So 0.6% for 100 milligray, and it's only 0.06% for 10 milligray. And as you can see, those figures are relatively high. So you have to be very cautious in exposing the unborn child to radiation, especially for leukemia. So what are the guidelines, in fact? Since May 2000, ask a woman if she's pregnant, or does she suspect to be pregnant, or do you miss the period? And what to do when the woman is pregnant, determine the conceptional age, inform the patient, talk with her. Is it possible to make a dose estimation? Is the dose higher than 1 milligray? And that's the dose that we normally receive in a year as normal population. Is there a justification to change? Optimization, if you have to irradiate the person, good medical practice, or when you have to perform diagnostic x-rays, and also making a report when the woman is pregnant. And this is, for instance, what can happen in radiotherapy. For instance, a patient develops breast cancer during pregnancy, and the normal treatment is 50 gray in the target volume, etc., etc. And the patient receives 50 gray. And here you can see what is the fetal dose related to the stage of pregnancy or the distance to the focal target volume. And you can see in an early pregnancy, the fetal dose is very low, 30 milligray, 12, 50. But when you can see later in the pregnancy, also the fetal dose will increase. This is the fetal dose of the whole treatment of 50 gray. And you can also see here that the position of the unborn baby is changing, and also that the volume, the target volume, is increasing when you irradiate one of the breasts. So what is the ICRP recommending when you have to terminate the pregnancy, for instance, that when you receive a dose below 100 millisievert or milligray, it's not justified based upon the radiation risk, because it's below the threshold of deterministic effects, and the chance, and it's below the chance of getting cancer is 0.6%. So that's for leukemias, and they consider that as a not very high risk. I consider that as relatively high risk still, but okay, that's my opinion. A fetal dose in excess of 100 milligray, there can be fetal damage, the deterministic effects, and the magnitude and the type of which is a function of the dose. The higher the dose, the more severe the effects is, and also the stage of the pregnancy. And in these cases, decisions should be made upon individual circumstances, and it's important that that the parents get good information from the doctors about a certain risk, about the risk that may be expected. Now we continue with the radiation exposure of pregnant workers. And until a pregnancy is declared, there is no special limit for women other than those applicable for any radiation worker. So once the pregnancy is declared, the maximum permissible dose to the fetus is only 1 milligray or 1 millisievert. That's the normal dose that you are allowed to receive, or what you are expected to receive in a year. And that's also what a fetus is allowed to receive in those 9 months. In the United States, they permit a dose to the fetus of 0.5 millisievert per month. So that's a little bit higher. Here in Europe, we always try to create an environment that keeps the fetal dose below the 1 milligray or 1 sievert during the pregnancy. So in practice, the employee employer creates working conditions that minimizes the radiation dose to the embryo of the fetus. So in that case, we avoid unnecessary radiation exposures, for instance, in the intensive care unit or operating theaters with old cobalt machines. Maximize the distance to radiation source, minimize the time, do not assist during fluoroscopy and interventional procedures, and do not assist during brachytherapy manual. Those are a little bit, restrictions. It's not a rule, it's a restriction. And in fact, pregnant staff should use protective devices. So Metany aprons like here, or you have the two colored code personal dosimeters or badges should be worn under the lead apron and also on the surface of the lead apron. The daily practice is very often alteration of the work. So in radiotherapy, that you're sitting behind a monitor or that you're involved in the planning or that you're doing administrative work. And then we come now on my last subject of the two talks. So the last part of the talk is the genetic diseases due to radiation. And the genetic diseases are attributed to mutations in the germ cells, either the male germ cells or the female germ cells. And they are transmitted to the progeny. And we call them hereditary diseases. First, I want to show you the radiation effect on the gonads, on the testis of the ovary, some DNA damage, chromosome aberrations, translocations, point mutations, what you can also see in the development of cancer, in fact. Genetic diseases, doubling dose and risk estimation, and overexposure, what to do. Radiation exposure of the gonads. The effects after exposure of the reproductive organs to radiation are dependent on the dose, the number of fractions in the dose rate. So these are deterministic effects. And then I talk about sterility. With the very low doses, we talk about genetic damage. And then it's a stochastic effect. And genetic mutation in germ cells are often the results of incorrect or incomplete repair of DNA damage and a fixation of chromosomal damage. And it's very important. Genetic damage can be reflected in future generation and can be inherited from the parents. Here are some deterministic effects, and the threshold dose for those effects for the testes is temporary sterility or permanent sterility. The threshold dose is very low, 0.15 gray, and you can already see a decrease of the production of the sperm. This is for high dose rates, but this is for high dose rate, a normal dose rate. But for the very low dose rates, it's 0.4 gray per year. Then you see temporary sterility. Permanent sterility, you see after higher doses, 3.6 up to 6 gray. And here for chronic exposure, also 5 times higher, about 2 gray per year, and you have permanent sterility. For the ovaries, when you talk about sterility, between 2 and 12 gray, but it depends on how old is the exposed female. Is the exposed female in the premenopausal stage? Then it's very sensitive because you only have a few ovums left. And then you're in the pre-puberty, you have a lot of still a lot of resting egg cells left. So that threshold dose is a little bit higher. And for the chronic exposure, it is a little bit higher than 0.2 gray per year. Those are for the deterministic effects. But in fact, when we want to do studies on the genetic effects of radiation, we haven't seen any significant effects in the genetic studies of the A-bomb survivors. And they have checked thousands and thousands of irradiated females and males. So the risks are mainly based on mouse data and on radiation-induced mutations. And those mutations were in the stem cell spermatogonia or in the resting oocytes. And for the genetic risk, it's very often the doubling dose, the DD method, is used, and that's in fact the dose that is required to produce as many mutations as those occurring spontaneously. So that's a doubling of the spontaneously arising number of mutations. And all genetic effects are the results of DNA damage. I mentioned that before, DNA mutations or the double-strand breaks that causes the chromosome aberrations. This is an example of a chromosomal aberration. Here you have a chromosome with two double-strand, with two chromosomal breaks. And here you see rejoining, but the rejoining is reciprocal. And those reciprocal translocations of rejoinings can be stable and they can be passed on to the progeny, and they may give rise to serious defects. You can also have dicentric chromosomes and acentric chromosomes. In fact, when you produce these chromosomes, then cells will die. So you don't pass them on to your progeny. Or in this case, 3, you have a rejoining with the previous part that was broken, but those mutations may be stable, but you don't know how much of the genetic material you have lost. So also the double restitution may cause changes in the progeny. And in B, here you can see misrejoining, that's a possibility. So upside down, they are stable. Periconcentric inversions, they are stable. But in many cases, the cell will still die. And also with the cell-centric rings and the acentric fragment, in those situations, this damage cannot be passed to the progeny. So, in fact, you're not too afraid of that. These are the more difficult ones that may cause mutations later on. This is, for instance, before, because we talking about the germ cells, and in the germ cells, before fertilization, you go from 2N to 1N. And here you have the normal chromosome, two sets of chromosomes. And here, this is at the meiosis, you have pairing of those chromosomes. And you can see here, this is the normal situation, that you have 4 different pairs, single pairs, so 1N in the gametes, because the other gamete also has 1N, and together you will end up with 2N. So then with 1 set of chromosomes from the father and 1 set of chromosomes from the mother. But what happens when you have a damaged chromosome? In this case, this chromosome is damaged and this chromosome is damaged. So you have a chance 1 out of 4 that you have a reunion between 1 and 4, and that will mean that you have a normal set of chromosomes in your gamete. But in all the other cases, you have translocations, spontaneous abortion you get because of the damage, because of the fact that the chromosomes are not normal and they are that different that you cannot produce any offspring with that. When you look at the changes that you produce and that causes the genetic diseases, we can have monogene diseases, and then there's only 1 gene involved. And the spontaneous frequency in a non-irradiated population is 2.4. Chromosomal diseases, there can be structural changes or numerical changes, and the spontaneous frequency is about 0.4%. And also multifactorial, they are very late, and you have the gene and the environment, and they occur later in life. And all those diseases follow the law of Mendel. So when you think that radiation induces genetic effects that are new or unique, that is not true. they rather increases the frequencies of the same mutations that already normally occur in that species. And I always remember and show this picture from the radiobiology book of Eric Hall about these children. My father was a radiologist and assures me that radiation is not hazardous. No, this won't happen. Radiation does not result in genetic effects that are either new or unique, but rather increases the frequencies of the same mutations that already normally occur in that species. So what kind of genetic diseases are we seeing in humans? Here, for instance, the diseases that follow the law of Mendel, they can be autosomal dominant, or they are sex-linked, or autosomal recessive, or you have chromosomal diseases. Now you see here the frequency per million multifactorial diseases, 71%, but they occur very late in life. And also the environment influences those diseases. There can be chronic diseases, so as diabetes and congenital abnormalities. So this is the frequency per million, but these are in fact the very severe genetic diseases. Here are some diseases that you can find and that are dominant, for instance, Huntington disease. So in the dominant case, only one donor delivers a mutation and you get the Huntington disease, Alzheimer, and for the recessive, cystic fibrosis, hemochromatosis, etc., sex-linked, for instance, X-ray chromosome, color blindness, hemophilia, and metabolic diseases, Pompe disease, and PKU. The spontaneous incidence of these diseases is about 2.4%. So when we talk about the monogenic diseases, we have more than 5,000 different genes involved in that. Multifactorial diseases is a gene plus the environment and occur at a later stage. And when we talk about the chromosomal diseases, structural is when the structure of the chromosome changes, and numerical, that the number of a specific chromosome may change. So we have an excess, for instance, for a certain chromosome. These are some calculations or risk estimates for the doubling dose, and I already mentioned that the doubling dose, and you have a certain risk. They also use the absolute mutation risk, but forget it. This is especially for the people that loves to calculate the risk of getting a genetic disease when you are exposed to radiation, and that is very, very low, especially because we take some measures when there is an accidental overexposure. To know a little bit more about that, just look at the spermatogenesis, and from maturation, from the spermatogonia up to the sperm, it's only 72 days. Take that in mind. So when you damage, for instance, one of the spermatogonia, it takes 72 days before maturation. So after 72 days, you have non-exposed spermatogonia or non-exposed offspring of the spermatogonia. The same with the females. It takes 6 months to mature. So a second meiosis, this is in fact before the birth situation with the oogonia with 2N, and then after birth. You have your meiosis, the secondary oocyte, and it takes 6 months every time to maturate to have an ovum. And at puberty, you have between the 400 and 600 mature oocytes. So what to do when you're exposed to irradiation? And we say about a dose of 100 or 200 milligray, it is recommended that 2 to 3 months for males and 6 months for females to be allowed to elapse between exposure to radiation and a planned conception. So when you take that in mind, then you don't have to worry about genetic diseases in offspring. Here are the risk factors for the total population. 0.2% per sievert, so that's very low. And we talk about, in radiation protection, about millisieverts. So you have thousands of a 0.%. Working population, 0.1% per sievert. And these were all based, these risk factors, on heritable risk effects for 2 generations, because when you have exposed people, one is exposed, but the partner is not exposed. Life expectancy was 75 years, reproductive age was 30 years, total population, 30 out of 75 reproductive population, working population is lower, only 1 individual is exposed. So this is in fact what I wanted to tell you. These are the important chapters in the radiobiology book for radiologists by Eric Hall, and this is, I think they already have a newer version of that, but I'm sure that these chapters will be here. And 2 important links here: IEA, ARBR, RPOP, Radiation Protection of Patients, ICRP, International Commission of Radiation Protection, and here's some important links for you to follow. Thank you for your attention. Are there still any questions left? Or new questions arising?
Thank you, Jan.
Second part?
You can stop sharing the screen.
Yes, I will.
Thank you very much. I'm sure there will be questions. I have one question. The first thing is, you mentioned about the those who are already exposed, the radiation workers, or
yes,
who are radiotherapy patients and whatever, and those people who are not exposed, and the risks are different. But we don't know who is exposed or not in most cases, because those people that we consider not exposed, perhaps he or she exposed it somewhere and she's not aware. So I believe that those people who are not exposed, really not exposed to radiation, the risk of developing some defects due to radiation, perhaps lower.
Yeah, but they use big cohorts of people for those risk estimations, and those people were not exposed to radiation at all.
Yeah. So it is perhaps impossible because we know who is exposed.
Yes, okay. You do.
But we don't know who is not exposed.
No, that's true.
It's impossible that we can.
That's true.
And the second is, well, the recommendations of the European recommendations for
ICRP, yes,
asking the woman between age of 12 and 50 to check if she's pregnant. Well, I don't know. It's possible here to ask to a 12-year-old girl, "Are you pregnant?" to get a radiotherapy, or "Are you pregnant?" to have an X-ray or CT.
But
who is doing that?
at least you can put a poster up.
Yeah.
In the waiting room.
Yes, we have, but it does not have. Well, there's a standard poster in the atomic energies.
Yes, I do remember that. Yes,
we are putting it, but it is not for. We only say if you think you are pregnant, that's not for 12-year-old girls.
No, that's true. That's true.
12-year-old is a bit.
In a lot of societies, it's not done to ask that question. I agree.
Oh, yeah. So that's true. At 12-year-old,
that's the reality.
Pregnant,
yes.
But well, in our case, it's very difficult, and I'm sure in Europe it's not easy as well. Perhaps.
No.
And well, any other questions from the audience? Beste, Zubi, Sarah, and others, please. You can ask your questions through chat, or you are already on the screen, and you can ask by raising your hand, and you can ask here. And I have also one more question. Well, the dose limits between Europe and America is different. Is there a study comparing?
I don't know. I don't know. It's just from the old data that that I know that, and that was published, but they never compared it, those big cohorts of radiation workers that received 0.5 milligray per month over a period of 6 months compared to 1 millisievert.
I think it's too high.
And the doses are too low to see a difference, because in that case, you might have a cohort maybe of 500 million people or so.
Okay, now we have a question from Beste again.
Mm-hmm.
And the question is, what time would you recommend to have a planned child in cancer patients who have completed radiotherapy?
I think it really depends if they get chemotherapy or not.
Okay, let's say no chemotherapy, radiotherapy finished today. And
in that case, it's recommendable. It can be done after half a year.
After half a year?
Yes.
Okay. Is it the same for all ages, or women 40 years old, 18 years old?
They don't discriminate between ages with these recommendations.
Okay, you say it's...
I can imagine that when you're younger and you want to have a child, that you can easily wait, or that is not so hard to wait a little bit longer, that when you're close to your 40s and the time is running out.
And for radiation workers, regarding the medical staff,
mm-hmm.
The radiotherapy workers, we are have more chance, because RTTs here, if
mm-hmm.
it's pregnant or planning to pregnant, okay, we can take them from the machine and we can
mm-hmm.
put them to
yes.
contouring at least. But for radiology technicians and nuclear medicine, they don't have that chance.
No, that's why they
only take image of the patient. They do nothing else.
But that's why they are recommended to use a lead apron, although at the end of the pregnancy that will be very hard, and also to stay away, far away from it, from the patient, from the radiation, because you have your the longer the distance, the lower the dose. Huh?
Yeah, this is a bit tricky, because also it brings a lot of legal issues. You know, if a technologist as a baby with a chromosomal aberration or something mm-hmm. may sue the management of the hospital, and you know, we have malpractice issues as well. It's really difficult situation.
Yes.
We have another question from Professor Ayşe Demiral. Here is the question. After in utero irradiation, does the risk of solid tumor carcinogenesis last also till 40, 50 years?
They haven't studied that, but I guess it will last the rest of your life.
It's always there.
Yes.
Okay.
The risk period, that doesn't mean that you will get it.
Yeah. Okay. But no, if there's a DNA damage, it will be there forever.
Yes.
Or
that's what the opinion is of in the world of the radioprotectionists.
Do you think it also affects the other generation too?
No.
So if you get some irradiation when you are in utero, then you have a child. Your child is at risk as well.
No, but when it happens, when the changes occur in a somatic cell, you don't have to worry about it. When it occurs in the ovary or in the testis, yes.
Okay. Sarah, Professor Sarah has a question. It's a popular and out of topic. She says, what's the risk of carcinogenesis after non-ionizing radiation? I think that's for cellular phones, right, Sarah? What you can say?
There's always a big debate on that, but the point is that non-ionizing radiation is not strong enough to make DNA damage. So from that point of view, I would say 0. Because you need a certain amount of energy to make a break. And the non-ionizing radiation don't have that energy.
Yes, that's theoretically. That's but no.
Yeah.
That's heating.
But I know from certain studies that non-ionizing radiation might have influence on the CNS, central nervous system, about the way you think or whatever. But that's completely different.
Yeah, but denaturation of some proteins and perhaps
yes.
heating.
There are certain tests for that, and they have seen some minor differences between the non-exposed and exposed people regarding attention, doing certain tricks, etc., etc.
Okay. Are there any questions from the audience? And I think I'm really surprised to learn that until 1950, 270,000 radiation workers, health workers died of radiation effects. Mm-hmm. It's very, very high.
But that's over a very long period of time, huh?
Yeah, very, very high. And regarding the number of the radiation workers at that time, it shouldn't be too high. Now we are millions.
Yeah.
It's very high. It's a pity. But it's good that now we don't have any deaths related to radiation, hopefully. Okay, then I see there is no more questions. I thank Jan Wondergem.
What's a pleasure.
Tonight, and it is recorded. Program is recorded. You can follow anytime afterwards. And I will distribute your presentations.
Yes,
to our colleagues. Thank you so much for that. It's good to have with you, Jan.
Thank you.
Some time, and thank you in your retirement instead of sailing with boat, and you join us this evening. And I thank all the audience for being with us, and Beste and Professor Beste and Professor Sarah Kamer for organizing this program. And Zubi for joining us as a guest from IAA. Thank you so much.
Thank you very much.
And I think next week is the last week, right? Sarah and Beste, can you inform?
Yes. Yes. The next week will be the last week. We will have an exam.
After an exam.
A quiz.
Quiz, yeah.
Next week's topic is flash radiotherapy. So if you would like to join us, we're welcome.
Yeah, we send you a link.
Yes. But it's a new way of applying radiotherapy. There are a lot of connections with tissue banking. Okay, thank you. Bye-bye.
Thank you. Have a nice evening.
Bye-bye.
Have a nice evening. Thank you. Thank you.